Welcome to the External Medicine Podcast. My name is Daniel Belkin, and I'm here with my co-host and brother, Mitch Belkin.
We're both medical students interested in non-traditional ideas and innovation. This podcast is our attempt to explore topics currently on the outskirts of medicine, topics not widely accepted by the mainstream, but that we believe merit a closer look.
This podcast is for educational and entertainment purposes only. We do not endorse any healthcare providers or treatments. Our views do not represent the views of any official organization or institution.
If you'd like to support us, follow us on Twitter at EXMedPod and sign up for our newsletter at externalmedicinepodcast.com/subscribe.
All right, we're going to keep this super simple today because we're interviewing the creator of simple.org, and it seems appropriate. And also, I am still recovering from COVID. Take it away, Mitch.
Today, we're interviewing Daniel Burka. Daniel Burka is the Director of Product and Design at Resolve to Save Lives, where he works on the web-based open source hypertension reduction application, simple.org. Previously, he was a design partner at Google Ventures, the creative director for dig.com, and the director of design for TinySpec, which later became Slack. Among his many, many impressive projects, he was the designer of Mozilla's website, as well as the Firefox logo.
We really enjoyed this conversation. And without further ado, we bring you Daniel Burka.
All right. We are here with Daniel Burka. Daniel, thank you so much for joining us today.
Well, thank you guys so much for having me. It's a real pleasure to be here.
Before we get started, do you have any financial disclosures?
That's an interesting question. So I work at a not-for-profit called Resolve to Save Lives. So there's not big financial disclosures there. But I should tell you that I'm also recently joined the board, and I'm an investor in a health startup based out of Pune in India called Loop Health, which provides primary care services and insurance for kind of middle-class Indians. And I used to work at Google Ventures, and so I still have carry in some of the Google Ventures funds, and Google Ventures does a considerable amount of life sciences investing. So I'm not sure how much of a conflict that is, but at least that's a full disclosure.
Great. So can you give sort of a brief sketch of your background and how you got interested in healthcare?
Sure. Well, I'll try to keep this short and tight because I've been designing for a really long time. But about 22, 23 years ago, when I was in high school, myself and some friends started a design agency together. This is like early days of the web where you could just kind of learn how to do design by seeing what other people were doing online and right-clicking and viewing source to figure out how it was coded. And so we started an agency, and I'm still really proud that that agency is still in business. And in fact, my twin brother is still one of the working founders who's still there. And it's called Silver Orange. So that's where I cut my teeth, is doing kind of small projects there and eventually building up and doing more interesting projects. And then one day we sort of accidentally volunteered to work with Mozilla on the branding of Firefox. And then I designed the Mozilla website at that time, and that kind of opened up some doors. And I moved to Silicon Valley and became the creative director at a startup called Dig, D-I-G-G, and then founded a couple of companies and sold one to Google. In between there, worked at the company that became Slack when it was still a game. So it was this kind of weird and kind of all over the place career. And then was at Google Ventures. And when I was at Google Ventures, we were doing I was a design partner there, which means you're kind of the senior consultant, and you get to work with like founders and heads of product on kind of their strategic design challenges and their product challenges. And one of the really interesting things at Google Ventures is that we did a considerable amount of investing in life sciences companies. So the life sciences team there is run by this guy named Dr. Krishna Yeshwant, who's this doctor in Boston, as well as a venture capitalist. And he's really brilliant. He's built this really strong team of kind of really diligent medical professionals who are also good investors. And that meant I got to work with all these companies that they had invested in. Companies like Flatiron Health, which is a big data oncology company, Quartet Health, which was like mental health, access to mental health company for consumers. And I found that work really fulfilling. And the more I thought about it, the more I was thinking, well, if I could wake up in the morning and do anything, what anything would I do? Well, I would focus more of my time just working on kind of hard problems, probably in the health space. And then I met Dr. Tom Frieden, who's the former director of the Centers for Disease Control under President Obama. And one thing led to another. And now I'm the director of design here, working with Dr. Frieden.
So for people that aren't familiar with Google Ventures, could you tell us what is Google Ventures and what's the relationship with the rest of Google?
Yeah, so it's really weird, right? You've got this. In fact, there's two groups within Google that are primarily on investing. There's a group called Google Ventures, and there's another group called Capital G. And Google Ventures, where I worked, is very similar to a venture, a traditional venture capital fund. So it's a lot, if you've ever heard of like Sequoia or Kleiner Perkins or Benchmark, they're kind of the big famous kind of venture firms in Silicon Valley. Google Ventures is very similar to these. The big difference, there are two big differences. One is that the limited partner is Google. So normally you have a bunch of rich people who put in money into a fund and you go and invest that money. In this case, Uncle Larry puts in, at this point, I think it's over $1 billion a year into the coffers, and they go and invest that. The other big difference is that many of the people who work there are ex-Google. Not everyone, but many people. So some of the DNA from Google, the strength in engineering and scaling systems, that kind of thing is part of the kind of the founding DNA of the organization. But it's pretty much straight venture capital. It's not a strategic investor, for instance. Like we weren't investing in things because they were necessarily interesting to Google to acquire later. It was because we thought they were companies that would be successful in the future.
Could you tell us a little bit more specifically? So you're a designer and you were working at Google Ventures. What exactly is the role of design in a venture capitalist fund?
Yeah. I mean, it's still a really unusual role to be a design partner at a venture fund. There are a handful of people who do it, but there's no like kind of playbook on what that means or what you do. In our case, we had a team, when I was there, of 5 people, so a big design team. And the thesis, there's kind of 2 theses. One is that, especially at the early stage of a company, by making good product design decisions and fundamental product strategy decisions, that you could be more likely to be more successful. So most of the role from a design partner was post-investment, and we had already invested in companies, and the general partner who had done the investment would say, hey, Daniel, I've been working with this founder. I'd love for you to go work with their team for a couple of weeks, sit down with them, think about their strategy, help them hire, help them kind of make some good key decisions early on. Like we invested in Slack, for instance, and we worked with them for a week on figuring out how their onboarding flow works. Because if you think about it, if you're familiar with Slack, the big challenge with Slack is the first person at your company who signs up is sitting in a room all by themselves. Because Slack fundamentally is a group, activity. And so we were brainstorming with them, basically, how could we get through that process so that first person gets in, understands what happens, invites a friend in, and now, they can fully understand kind of the power of the product, before they commit to purchase. And so really early on with Slack, we worked on a problem like that. And you can see with a company like Slack that later on was worth billions, how little decisions early on create large inflections and, are worth the investment. The design team probably cost a few $1 million a year in budget at GV, but if you can return a handful of investments like Slack that return hundreds of millions to the fund, that's how the high end of venture capital works, is small inflections, large returns.
So how did you get interested in healthcare specifically?
So this type of engagement that we were doing at Google Ventures was really interesting, and particularly when I worked with, say, Flatiron Health in New York. You realize that healthcare is both more meaningful. I mean, this is the kind of the sanctimonious side of it. It's like, oh, I left because it's more meaningful. But it's also just much more complex, right? Like a big part, Flatiron was building an EHR for managing oncology clinics that was feeding real world evidence-based trials, right? And so both sides of this are really complicated. EHRs are, especially for oncology, really complicated. And then the science side, the research side, where they were using that data, to inform drug trials, super interesting and super complex. And I worked on consumer internet stuff for a long time. The company Dig that I was a creative director for was basically, if you're familiar with Reddit, it was the precursor to Reddit, in between Slashdot and Reddit. That stuff's fun and it's kind of hard, but it's not an EHR, and then you work on an EHR and you're like, oh, this matters to people's lives a lot. And it's really fucking hard. Like, for the right kind of person, that's a real challenge. And so I do, wanted to apply tech and design to meaningful problems in the world. And healthcare is kind of one of those kind of obvious spots where you really can kind of flex your muscles and potentially do good.
So you talked a little bit about your background in design at Google Ventures. What does someone who has a background in design have to offer healthcare and healthcare professionals?
Yeah, that's a great question. I think, despite it almost being 2022, I think a lot of people think of design as choosing nice fonts, choosing good colors, maybe designing, what the user interface looks like for a product. And that is design. Design's kind of a big umbrella. But design is a lot more about problem solving. I mean, there's a very famous Steve Jobs quote, which he says, design is how it works. And if we want to make products that are more human and more reflective of people's real circumstances, design is one way of looking at the world. Don't get me wrong, I'm not saying design's the only way of looking at the world, but design thinking, design, problem solving with design applies really well to an area as complex as healthcare. For instance, where I work, so I work primarily in India, Bangladesh, Ethiopia, and lately in Nigeria. And most of the technology that you see deployed in these places, not that different from American healthcare, most of it has been driven by technologists, so engineers. And so it's technically very powerful, but not very user-friendly. And in places like India, where you see, a typical clinical visit is between 3 and 5 minutes, you see how unrealistic most engineer-driven or even health expert-driven software is in the practical experience of clinicians and patients on the ground. And the kind of the application of design here is to come in, understand the constraints, understand the wants and desires of the different actors in this play. You've got patients, you've got clinicians, and different types of clinicians, you've got public health professionals and administrators, and trying to figure out what each of these people needs, what the constraints of the system are in terms of resources, time, and geography, and then figuring out how can we build a system that caters to as many of these needs as possible that actually works in places where most technology doesn't work. And that, to me, is design, this type of problem solving, human-centered problem solving. What do all these well-meaning people need? Can we make it work for them?
Could you talk a little bit about the actual process by which a designer comes in, understands the constraints, understands the different perspectives that patients, physicians, technologists brings, and then is able to actually integrate that into something better?
Yeah, sure. So there are many ways to do this. So I'm going to describe one way, but people write books about this stuff. So when we were starting to work, I work on a project called Simple. If you want to look it up, it's simple.org. which is a tool for managing large-scale hypertension control programs. So a country like India wants to, work on non-communicable diseases because, it's a high burden of disease. And they need to do all these public health things in order to implement a program. But fundamentally, they need a system of record so they know where things are working, where things aren't working, so they can get feedback loops so they can improve the system. Well, the first thing you do is, we did many activities at the beginning. The first thing we do is look at kind of precedent. What's already been tried in this space? Because you don't want to reinvent the wheel if you don't have to, right? And so we looked at tuberculosis, for instance, has some pretty good paper systems. This guy, Carol Stieblo, had designed kind of what Tom Frieden thinks is the gold standard for kind of a registry system for tracking a program with TB. So we looked at that. We looked at some kind of digitized version of Stieblo's reports that were okay. We looked at kind of other technology that was currently being used in low resource environments, things like Damagi ComCare, things like DHIS2, which is a project out of Oslo, to do that. But then you go off into the field. I mean, you can't do too many things without actually spending a lot of time with healthcare workers. And this sounds self-evident. I mean, you guys are probably looking at me and you're like, yeah, no, duh, of course. A lot of software is designed from capital cities or designed from, a big country in the West, and then just dropped off at someone else's doorstep to be used. Even in a place like India, a lot of tools are designed in Delhi to be deployed in rural facilities. And they're designed by health experts, but those health experts haven't treated patients, especially not in a rural clinic, in decades. And so they're really out of context for what's happening in the field. So in our case, we went and spent time in Punjab, in Kerala, and in a couple of other states in India. And what we're doing is watching current patient workflows, watching current data systems. So I was just literally doing this 2 weeks ago in Nigeria. So what we do is, find the hospital administrator and have a talk with her, and then ask her, okay, introduce me to a patient who's willing to talk to me, and let's walk through the clinic together. And so you see, you walk in the front gate off the street, you get your outpatient slip, you wait in line 20 minutes to get your outpatient slip, and then you get put in another waiting area before you get your blood pressure taken. And then a junior health nurse takes your blood pressure, sends you inside to the medical officer to be diagnosed, who sends you to the pharmacy. And the patient the whole time is holding a piece of paper, and the clinicians are filling out big registers. And so you're like, oh, okay, I see the current data flow. I see the resources available within this space. I'm timing a lot of things because I want to know basically how much time do you really have to do activities. And then you're starting to think, okay, who needs data at which points? What can we possibly do in this scenario? And if you visit enough clinics, you can start seeing patterns of what works and what doesn't work. And of course, you can also just straight up ask the healthcare workers. You wouldn't believe how few people actually ask healthcare workers what they want, especially not big, important people in the Ministry of Health. They often just tell people what they should be doing instead of listening to what they want. So that activity is super important. But then we work with the health experts. What are the feedback loops you need? What are the data requirements you think you need for managing the system? And then we try to marry the constraints, the needs of the healthcare workers, the needs of the patient with the kind of the interests of the public health officials. And the really interesting thing is, in a place like India, where they see a patient every 3 minutes, or a place like Bangladesh, where they see a patient every 2 minutes, it really, in a way that's very exciting, it really narrows your focus. If a clinician has 2 minutes per patient, you have maybe 20 seconds to do data entry. I mean, realistically, within a clinic, if you ask somebody to do more than 20 seconds of data, they either won't do it, they'll do it badly, or they'll put in fake data just to get through it, because they didn't come to work today to enter data into a piece of software or even to write it down on a piece of paper. They came to treat the patient sitting across the table in front of them. That is their primary interest. And so, we looked at these constraints. We identified kind of what data flows need to happen. We identified how narrow this time period is. And then we designed prototypes. So this is a big thing that we did a lot of at Google Ventures is prototyping and user testing. So once we understood the kind of the broad area of the challenge, we created software prototypes really quickly, like within a week or two quickly. Like they're very much like popsicle sticks and masking tape. It looks like software. Like if I put it on a phone and handed it to you, you would think it was real software, but it's very much the facade of software. There's kind of nothing there. But I can test an idea with you and see if it works. So we were testing kind of workflows in an app. No, you can't see my finger quotes in the audio. I'm giving finger quotes, not real software. And we test that with healthcare workers. Again, it's like, I can imagine what works when I'm sitting in New York or Bangalore, but the real truth is putting it into a real healthcare worker's hands. And once we have prototypes, that seem to be working, that seem to make sense to healthcare workers, then we started developing real software. So you could see the difference here between a rigid engineering-driven software process and a process that's more holistic, that's design-driven.
Just to clarify, previously you were talking about Resolve to Save Lives, and now we're talking about simple.org. What exactly is the relationship between Resolve to Save Lives and Simple?
Yeah, I'm sorry for the confusion. Simple is a project that came out of Resolve to Save Lives. So I work at Resolve to Save Lives, and we create an open source tool called Simple. So Simple is what we call the software, but the organization is Resolve to Save Lives. And right now we're the only funder of that project. But over time, that may change.
Can you tell us a little bit more about Resolve to Save Lives, what the organization does, and what you're trying to do?
Sure. So Resolve to Save Lives is primarily a public health organization. So basically, when Dr. Frieden, who was the head of the Centers for Disease Control under President Obama, when he left as the new administration came in, he was trying to think, well, what's the largest positive impact he could have on the world? And he saw two primary areas to work. One is on epidemic preparedness, which, this was 4 years ago. You can see, obviously, that was a good idea. Maybe could have started a little earlier. And the second idea is to work on cardiovascular health. So hypertension, high blood pressure, alone is the biggest killer in the world. And none of us think about it that way, right? Because heart attacks and strokes are just normal. Everyone's got an uncle who's died from a heart attack, and that's just the way the world is. But it's not the way the world has to be. Just by controlling hypertension, you could save 100 million lives in the next 30 years. And so Dr. Frieden and Mayor Mike Bloomberg wrote an article in the Lancet laying out that plan. And Tom raised a considerable amount of money from donors to help countries, large, low and middle income countries, to implement scaled up hypertension control programs, and also to tackle the root causes of hypertension. Things like we work with Tedros at the WHO and WHO Geneva on banning trans fats in the world, and we work with countries on reducing sodium in foods. Kind of other upstream things about hypertension.
So hypertension obviously causes cardiovascular disease, strokes, et cetera. And all that together is, you said, the number one leading cause of death worldwide.
By quite a considerable margin. Yeah.
It's interesting that the specific interventions that are being proposed and are being implemented by Simple are basically things that we kind of take for granted in the developed world. Hypertension management, tracking of blood pressures, and a lot of the emphasis on funding abroad goes towards sexier things like tuberculosis or communicable diseases. Why do you think there's been so little emphasis placed on the biggest killer?
I like how you described tuberculosis as a sexy.
It's not sexy like malaria. I'm not an expert on this, but I think from what I've seen, a big part of it is just we all take it for granted. It's just what happens in the world, and it's also seen as it's not research. As you said, Mitch, it's not like new science. It's not something that's hard to do. It's just really difficult. We have to take the lessons from places like the UK or Canada that have done quite a good job of improving hypertension control and apply them to huge low and middle income countries. It's interesting, actually, that you said that higher income countries have kind of tackled this problem, but in some ways they haven't. A few countries have. Canada's got a very high percentage of control for hypertension, for instance. But when Tom was the head of health for the city of New York under Mike Bloomberg, they noticed that while doctors were treating hypertension, none of them could tell you how many of their patients actually had their hypertension controlled. And a lot of patients weren't being treated longitudinally. They were just being treated transactionally whenever they happened to come to care for something else. And so one of the big challenges with chronic disease is that you do need to return to care. You do need to maintain, if you're taking medicines to control your hypertension, you need to take them regularly, or else you're not getting any benefit. And even countries like America today does an okay job of it, but not a great job. Whereas countries like Nigeria or Ethiopia, Bangladesh have extremely low control, like even compared to America. And there, at a public health facility in particular, it's not even like they take your blood pressure every time you visit the clinic. There's not necessarily even a functioning device in the clinic. And so the opportunity is huge, but the difficulties are simple, but very difficult because of the scale.
Going back to simple.org, can you define what a lightweight or ultra-thin EMR is?
Yeah. I hesitate. I know I wrote an article at one point and called this an EHR. I think even calling it an EHR might be a bit of a stretch. The goal of Simple is to create a longitudinal record where no longitudinal record existed before. So most patients being treated for hypertension or diabetes in a country like India or Bangladesh or Ethiopia is being treated very transactionally. People usually came to the hospital for another issue, and they happen to get a blood pressure taken today. They happen to be treated today, and their blood pressure will be written down on a piece of paper, and then the patient will be sent home, and that piece of paper will never get connected to their next visit, right? And so when we say ultralight, we mean ultralight. Like it records almost nothing, but it records almost nothing extremely efficiently. So as I said, because the clinical visits are so fast, we're trying to record useful information in 20 seconds or less. Well, in less than 20 seconds on a return visit, I can get your blood pressure measure, your blood sugar measure, and your current medicines for hypertension or diabetes. That's all I need, though. With that information, I can tell you for the patient, we can look at their blood pressures over time and see if they're trending down. And if their blood pressure is elevated, we can look at what medicines they were taking last time and treat them to protocol and titrate the medicines today. Right? So there's a basic treatment protocol as part of the hypertension control program. So you're looking at a poster on the wall because you may not be a very highly trained medical officer. Now look at the app and say, oh, you're elevated a month ago, you're elevated today, and you were on amlodipine 5 last time. I'm going to add losartan 50 to your, I'll titrate your medicines to losartan 50. So you get all of that. And I know when you should visit next. I can do all of that in 20 seconds. Well, if I know when you're going to visit next, and during the first time I enrolled you, I added your phone number, well, now I can automatically text you. So we send automated reminders to patients in a place, this is, you guys might think it's like totally normal to get texted from your doctor. It's like totally not the norm in many countries. So we're texting patients to return to care. We can create line lists of patients who are overdue for care to give to a community health worker who works in the village to go off and find people and bring them back to care, or distribute medicines locally within the community. So you get all these good benefits in a health system in just 20 seconds. So you get the feedback loop for the patient. I can see if I'm getting healthier. You get the feedback loop for the clinician. is this patient getting healthier? And if they're high, if they're uncontrolled, how do I titrate their medicines correctly? That's all in the app. And then above that, if I'm the medical facility administrator, so I'm the kind of the head doctor in a small hospital. Well, now I can look at, I've got 1,000 patients in my hospital with hypertension. How many of them returned in the last 3 months with a controlled blood pressure? Well, I can see how I'm doing and I can compare myself to my neighboring hospitals. If I'm managing a big group of hospitals in my area, I'm the chief nodal officer for NCDs in my region. I can look at how are all the facilities in my region performing, and then I can look at the low performing ones and see why they're low performing. Is it because patients aren't returning to care? Is it because patients are returning to care but the blood pressures are uncontrolled? Is it because patients aren't being treated to protocol? I can see that all from my desk by looking at a dashboard of information just based on that little tidbit of information that we pulled in from the Android app during clinical care. And so you could see it's like almost nothing, but it's the key drivers to drive feedback loops into the health system. So all the way from a national level down to the facility level, down to the individual patient, you're creating better and faster loops. And typically, in all of these places where we work, this was done on paper. And paper's got lots of, it's got lots of upsides, never loses power. Everyone knows how to operate it. This is great things. But at the scale of hypertension, it becomes a huge burden on the health program to manage a paper system. And the feedback loops take a whole quarter to come back because someone's got to go and collate the information and submit it to the center and then generate reports and then analyze those reports and then make a change in the health system. And then a whole quarter later, see if that change had any effect. And I liken that to when you stay in a cheap hotel room and it's got different knobs for the shower and you can't tell which one's which. And when you turn it, nothing happens. And then by the time the temperature changes, you've already turned it again. And now you have no idea what's going on anymore. This is the problem in every health system in the world trying to manage things like non-communicable diseases.
There were a number of very interesting choices that Simple made. You kind of focused in on the selection of only a few key data pieces to include at each visit, the goal of which being the less time that it takes clinicians in the field to actually enter the data, say 20 seconds, the more likely they are to actually enter that data and to do it accurately. And you said blood pressure today, medications if they're being changed, next appointment date. It seems like there's a lot of different things you could always tack on one additional thing for management of diabetes or kidney problems. How do you select what it is going to be included in the final version? And I guess an addendum to that would be and how do you prevent basically mission creep leading to the software becoming more and more unwieldy?
So that's a really, really good question. The first method is relying on the user research we're doing in the field. So it's not Daniel has an opinion that we should have less things in the app. It's I've been in 40 facilities and we've timed people doing activities, and realistically you can only require so much time. And I've timed people using the software, and everything we add adds 5-6 seconds to recording. That will take us over our limits. That works okay. It's actually better than you would think. To convince people, having some good stories about what it's like to work in the field. It helps to have experts. When I work with Tom, Dr. Frieden, it helps that he shares this opinion and he's able to kind of push back on the public health people, and we have a discussion. And this is going to sound ridiculous, but calling this project Simple is the greatest branding work I've ever done in my entire life. And I've got to work on a bunch of interesting brands over the years. When we were naming this thing, it was originally called the Red app because the interface was red. It was kind of the code name for the app. And we were trying to think, what should we call this thing? And obviously you should call it something to do with hypertension or non-communicable diseases, right? The Heart app or something. And we were debating those names. And then I was like, well, a lot of good brands are based on kind of what's the differentiating factor between this and anything else. And I was like, it's the only one that's simple. It's the only tool these healthcare workers are probably ever going to get to use that's as easy to use as WhatsApp. And they all know how to use WhatsApp. So like, maybe we'll just call it simple. And I swear to God, yeah, this sounds crazy because I'm not actually like, I don't think brands are magical or anything generally. But when we're sitting with a Ministry of Health and they're sitting there and you hear the official come up and they're like, we definitely need serum creatinine labs. We can't possibly, prescribe all drugs unless we know if the patients had their labs or not. And I sit there and I listen and they're like, okay, to do that, we would have to ask this question. And then that other question definitely would need to be asked. And then we need to connect it to the lab system. And then you see them like calculating it in their own head. And they're like, hold on, that's not going to be simple anymore. And I'm like, yes, this is the greatest thing ever. And they talk themselves out of it. I've almost never had to like kind of be mean about it. I'm just like, they generally talk themselves out of it and we keep it simple. And the simplicity is not just because of speed either. It's also because it's easier to train. And this is a huge issue in non-communicable disease clinics because there's giant staff turnover. If your nurses are turning over every 3 or 4 months, most software is so complicated in facilities that you have to undergo training, like official training to use it. And so if someone leaves and the next person didn't get the official training, the software will just sit on the table for the next 6 months and no data is going in. Whereas if you keep it simple enough, you can train it in the field, easier to use, and the outgoing nurse will train the incoming nurse and the data keeps flowing. So a lot of nice side effects.
I guess another reason it's good you didn't call it the red app is there are all sorts of other potential connotations there. Yeah. Might have helped getting it into certain contexts, of course.
Yeah. It's mostly Americans who make that connection, yeah.
So, when I'm looking at simple.org and I think about other places in the world where, take India just as a specific example. So, top 3 diseases that are top 3 killers are cardiovascular disease, COPD from smoking, and strokes. So 2 of the 3 you're hitting by addressing hypertension. But for tobacco use, or say depression or cancer or other issues, you could envision additional people trying to put forward other applications to address smoking and to address cancer and to address depression. So I guess I'm just sort of curious about like how to maybe not scale up simple, but to like actually address other issues. Would the movement then be, we need other apps to address this? Or how would you go about designing or trying to modify this concept to address the other major killers?
It's a really good question. And this is one of the big challenges, especially in primary care. Let's think of the primary care context. Hypertension is not the only thing that doctors are treating in primary care, right? They're doing a lot of antenatal care. They're doing HIV, TB, malaria, dengue. They're treating all kinds, COPD. They're treating all kinds of things in primary care. And one of the risks to a product like Simple is it's good and it's tackling a very deadly problem, but a relatively narrow problem. Even if it's a lot of your patients, even for them, it's not the only thing that they're dealing with. Many patients are comorbid with other issues. And there are kind of a couple ways to think about this. One, the India actually has recently published a national health blueprint that came out of the Ministry of Health, the Federal Ministry of Health, that is an excellent guidebook, which is basically saying the federal government will make some core building blocks that connect systems. National health IDs, you actually know that, the patient Dan is the same patient Dan in my system as in your system. You need a facility registry. So I know that when Dan visits facility A, it's the same facility A as in another system, right? Or else you basically don't have the building blocks for interoperability between systems. And it also spells out how a health wallet should work, where patients can actually get their own health record and take it with them, whether they're going to private care or public care, which is very fluid in a place like India, and gives patients the control over their own data, which hasn't been achieved in very many countries at this point, certainly not in America. So that's one approach, is to give a building blocks approach and build an ecosystem where tools are relatively interoperable with each other. Because then you could have even within a clinic, you could have 5 or 6 different digital tools being used, but patient data flows seamlessly between them. Might be a pipe dream that it could really be seamless. I mean, if you look at the United Kingdom, you can get treated in 2 different NHS hospitals within the city of London, and your data doesn't flow between them. So very challenging problem. The other approach is to do some of those things, but to also simplify other disease categories. And I think that's what you're getting at, Mitchell, and that's an approach that we're actually trying right now in Nigeria. So instead of using Simple in Nigeria, we're taking what we know works from Simple in the 5,000 hospitals in India where Simple operates, and we're applying it to a different piece of software called DHIS2 that comes out of the University of Oslo. It's an open source tool out of Oslo. And DHIS2 is used in many countries already, like 60 or 70 countries. And a place like Nigeria already has digital infrastructure for managing and thinking about data sovereignty and security issues and kind of managing a program around other programs. And what we're hoping to do is make a module within DHIS2. And we just tested this in the field a week and a half ago in Kano State and Ogun State in Nigeria. So make a NCDs module, but then start adding in more basically digital registers into the system. So typically in a facility in Nigeria or India, they'll have registers for every different health program. But if we could digitize those registers to create a longitudinal record for every patient, as well as driving these feedback loops I was talking about earlier, I think you get a lot of the same benefits as hypertension for these other disease categories. I don't know if everything can be boiled down like this. You can't boil down a complex cancer case like this. Humans are complicated. But I think some of the more basic things around, like tuberculosis is already managed with DHIS2 like this. So if I was in a facility and I had an antenatal care program, TB, NCDs, and maybe add in, a couple of other kind of high percentage disease categories, I could cover a much broader group of my patients and start creating better feedback loops within my facility about who I'm making healthier within my catchment area, and helping return patients to care at a regular basis to be much more proactive about their disease.
Just to clarify, so for this DHI modules, is this trying to address the problem of interoperability by actually having No, it's not really about interoperability. It's about doing more things within one system. Sorry, this is going to be a bit of a complex answer. DHIS2 is interoperable with other systems. So they build on the FHIR standard. So it can be interoperable. But I'm talking about making a more multi-use tool for using within primary care than Simple. Simple's really good at just NCDs. And extending it beyond that is going to kind of cannibalize its usefulness. So in a very high velocity NCD program in a place like larger hospitals in India, I think you need the Ferrari. I compare Simple to the Ferrari. It's a little hard to maintain. It does one thing really well, but it's real fast. DHIS2 is more like the Toyota pickup truck. It's not sexy, doesn't go as fast, but it's easy to get parts for it, carries a lot of stuff, really versatile, won't win the race, but it'll get you over the mountains if you need to get there, and it'll get you down the highway if you need to go. I think DHIS2 is that kind of versatile tool for some of these low resource environments. And it's already being used for quite a few programs. And if we can get it optimized for a high population problem like hypertension and diabetes, I think we could work down from there into some other categories.
the vision in the next 4 or 5 years, I'm hoping we can kind of come up with a toolkit for primary care that's really broad enough to work, but simple and narrow enough to be practical. You implement a full EHR in these places, you drop Epic or Cerner in there, and like you don't even have power for 3 hours out of the day. Like, what are you going to do?
So what type of car, using your car analogy, would Epic or Cerner be? Is it like a Hummer?
I was going to say like a super tanker or a cargo ship. They're a lot. Yeah, Hummer's a good, I was kind of thinking that too. Yeah.
I guess one other question about Simple before we move on to talking about Epic and Cerner and, the future of EMRs. You decided that Simple should be used on doctors' home devices. How did you end up making that decision?
Yeah. So this would be a fairly radical choice in America. And I'd be happy to talk about this with other experts. I think it's a decision that still makes me a little bit uncomfortable. So what we've done is we've deployed Simple on many clinicians' personal Android devices. We take basic security precautions. The data on the device is encrypted. It gets unencrypted with a passcode before the clinician uses the app. So if you hand it to a family member, for instance, they can't see patient data. Data in transit is also encrypted. The reason we did this is a fewfold. In India, it's very common for clinicians to have good Android devices in their pockets. And the device that you have on you is the best device to use to treat a patient. If I have to go searching out where's the tablet to go record patients, that's a big problem. They're also well maintained. If I crack the screen on my personal device, I go get it fixed because I want to send WhatsApp pictures to my mom. If it's the clinician device, no one cares about it. No one will fix it. If you lose the power cable, no one's going to power it up. It's always somebody else's responsibility. And then it's no one's responsibility because no one's in charge of maintaining things. This is one of the big challenges in a place like India. One of the unfortunate things when you visit hospitals. Great start to programs, and then they're not well maintained. Also, because we can deploy more quickly. If you have to do huge procurements of devices, we've about something like 30,000 users right now using Simple every week. If you need to acquire devices at that scale, not only is it expensive, but it's a huge logistical nightmare of acquiring and distributing those devices. So we take a mixed approach. Probably about 90% of the users in India are using their personal devices, and in some places where are particularly poor or where there aren't available devices, we have been purchasing. But yeah, it's an unusual decision. It certainly wouldn't pass HIPAA requirements.
One more question about Simple. You really focus on conducting research on users in the field and actually going to the specific cultural context, be they Nigeria, India, Bangladesh. One question I have is Simple the same in all of those different countries, or are there variations in the actual app?
It's a great question. Simple is 95% the same in every country. It wasn't planned to be that way. When I went to, we started in India, so we built specifically for the Indian context. We hired a team of engineers and designers and user researchers in India, to understand the local context and are able to go into the field fairly frequently to see what's going on. And so we originally designed for India. We have the philosophy, if we only ever succeed in India, we've succeeded. 1.4 billion people, it dwarfs almost every country except for China. So the original intent was to do that, and then we expanded to Bangladesh. Unsurprisingly, Bangladesh has a lot in common with India. We felt fairly confident, expanding to Bangladesh. Then we went to Ethiopia, and the first thing we did before we even considered implementing Simple there is we have a local health team in Addis, and I flew to Ethiopia and visited a bunch of health facilities with them and talked to them about what's the context. It's kind of shocking how similar primary care is in Ethiopia as to India. The same thing, I was just, as I was saying, I was just in Nigeria. Rural primary health clinics in Nigeria are also I've never been to Nigeria before a week and a half ago. And Nigeria as a country is very different from other countries, obviously. But a primary health clinic is shockingly similar in terms of the resources available, the types of medical devices in the clinic, the way records are kept. I was very ready in all of these countries for things to be very different and for us to have to make major shifts in how the app works. But other than changing the format for addresses and adding some things like local health IDs and a few local things around, like some countries, typically you've got a treatment supporter, like someone in your family who is helping you with your treatment. That's culturally different in Nigeria, for instance, from another country. But other than some small things like that, the app is almost the same. I mean, the drugs lists are different. Whether you measure, blood sugars in millimoles or milligrams per deciliter might be different, but like surprisingly similar. We translate it into 13 languages right now, but largely the app is the same.
Let's say that Epic or Cerner hired you. They offered you enough money that you were willing to stop doing what you're doing, at least temporarily, and work on with their
Lord,
EMRs.
That better be a lot of money.
I'm curious, how would you go about improving one of the current really big EMRs like Epic or Cerner? Where would you even start?
I don't want to even pretend I would know. I mean, the big things, so I know just a little bit about the big EHRs. I wouldn't say I'm an expert, but I mean, one of the big challenges is how focused they are around billing. I mean, if you structure it fundamentally around how do you extract money from your patients, that's not necessarily a great approach for patient care. I think the one place I might start, and we were talking about this at Flatiron Health. So I was working with Colton Bunny, who was the head of design at Flatiron Health, is probably around the clinician note. I think the note for clinicians, the way that's currently done in most EHRs, where you carry over everything from the previous visit and then just keep adding cruft and more cruft to a patient's visit and not really focusing on kind of what's changing over time. I think that's probably one of the big levers that you could pull on to significantly improve both the clinician's life and the patient care. But that's, I wouldn't say I've got any radical insight here other than that seems like a node I would focus on.
So even if you didn't have radical insight, I'm just really curious about your process that you would go through. Because, as we were talking about earlier, you really put design as being a field that can become the center organizationally, not just of the typography, but really in like understanding different users and goals and trying to integrate them all together. So would you start off with what? I really don't know.
Well, okay. So I would take a similar process to what we did with Simple, which is watching how clinicians, and patients move through a hospital, what they're recording, what they need to know at a given point to make a good rational decision about care, right? And both the patient and the clinician making good rational decisions, and especially thinking about things like task shifting within a clinic. How do I give each of the characters? Because obviously American clinics are much more complex about who's giving care at a given moment. And really good hospitals in America are doing really well at moving care down to kind of lesser, nurses and registered nurses within facilities, for instance. And that kind of supporting that ballet would be really important. But the unpopular answer I would give you is the first thing I would do is go meet with the business teams at these EMR companies and figure out what are actual incentives. Because the way that these things are designed is fundamentally related to how these businesses operate. I mean, this is one of the challenges of capitalism, right? Is how are they selling this thing? Who's buying it? And it's not, you guys, when you go work at a hospital, aren't choosing which EHR to use. Some business person who is an administrator at the hospital chooses the EHR. probably with some input from the clinicians, but they're also looking at the bottom line of how does this drive our business goals as a hospital. So the part I didn't tell you is that when I first joined Resolve to Save Lives is I spent a decent amount of time with Dr. Frieden figuring out why he wanted to do what he wanted to do and how he was going to measure success. And so I didn't have to twist his arm to say that design was important. He kept saying the 3 S's: speed, simplicity, and scale. And if you come out of Silicon Valley and someone says speed, simplicity, and scale, you're like, yep, that makes sense to me. That's language we use that totally makes sense. And then his idea of using those levers was purely around saving lives. I mean, it's nice to work in an organization that writes its motto right in its name. I mean, resolve to save lives. And he will often say, the decision we make is always about which option will save the most lives. And so I would go to Cerner or Epic or whichever Acme EHR company and be like, well, how do we measure ourselves? What are we trying to do? Because if you don't have alignment from the top about basic objectives of what our incentives are to do what we're doing, it will constantly, design will be on the back foot and be ineffective. And you see that at startups all over Silicon Valley that talk a big game about design, don't do shit because it's not aligned to their business interests.
That's interesting. So start with the actual, how are people making money from this, and try to understand as a result of that what the incentives are in the actual product.
Yes. I mean, that doesn't sound very nice, but yeah.
It does.
I mean, that is one of the big problems with, capitalistic software systems, which is almost everybody. You'll almost always make the decision that makes you more money.
Lately, I've seen a lot of companies that do direct-to-patient applications for healthcare tech, as opposed to applications that are sold to hospitals like, say, an Epic or a Cerner. How much do you think these direct-to-patient models will be involved in the future of US healthcare?
When you say direct-to-patient, you mean connecting a clinician directly to a patient, or do you mean like the AI things that are like Ada Health and so on that are trying to treat patients mostly with an AI and then connect you to a clinician if it's more complex?
I was talking about the former, not the AI.
Okay. Yeah, I'm somewhat skeptical of the AI. I mean, we invested in One Medical when I was at Google Ventures, and as I said before, I work with Loop Health in India, which is I'm on the board, which is a company similar to One Medical, where it's insurance. Your employer buys it as insurance, and then all the employees get good access to primary care as kind of a conduit to making good decisions within the health system in India. Yeah, I think that model is really good. I mean, I wouldn't have invested in it if I didn't think it was good. I think, particularly in a place like India, which I'm surprisingly much more familiar with the Indian health system than I am with America's. I think one of the big challenges is just navigating the system. I suspect this is also true in America. Your gateway to making kind of which expert should I be talking to when I'm suggested something, is that actually, what I should be doing, like, pharmaceutical choices, for instance. I get told by my cousin who's a medical resident that, a certain type of wellness is important. Is that legitimate? And having direct access to a primary care doctor, even in a less formal setting, like having the ability to chat online with your primary care doctor, or a kind of an employed doctor by your network who's available to chat with you, I think is excellent. And you see this like in the NHS system, for instance, in the UK. Is like I had an issue, about a year ago, and maybe I'll be honest with you, I had blood in my urine, and I was like, oh my God, everything I've read online, like I have cancer and I'm dying, many of your patients, I'm sure, feel this way. And there was a men's health number on the NHS website, and I was able to call it and immediately talk to a professional. And they were able to talk to me about whether this was an issue that required actual medical care or if I should just monitor my symptoms, and it was probably nothing, and which it was. And I was like, why isn't all healthcare like this? Like, that's amazing. And the nice thing is you can really scale a system like that. That one person's on the phone can manage 20 patients, a day, 20 or 30 patients a day. It's quite efficient. And they don't have to be, a super experienced expert. They just have to be able to do a lot of triage. So I'm not sure if that's what you were asking, but I think that type of system has a massive amount of potential to bring a more human element to the healthcare system before you escalate all the way up to, creating an appointment a month from now with your medical professional and having to trek across town to take the appointment. I think, probably during COVID too, we've seen the rise of telemedicine. It went from being a vague thing that was sort of done and might be the future to being a fairly obvious thing for a lot of cases.
We have a few rapid fire questions to finish off this interview. The first one is, what important development or developments in design have happened in the last 10, 20 years or so that you think people outside of design should be aware of?
The big one is to me is the advancement of prototyping tools. So when I was, 15 years ago, when I was doing design, if you wanted to prototype something, you had to code it up. And then a tool like InVision or Marvel came along. These tools are still around, and they were explicitly made for making very realistic, very quick prototypes. Then Figma came and ate their lunch, which is kind of the most popular user interface prototyping and design tool now in the market. And the ability to make very quick prototypes, get them on a device so you can put it in someone's hand, it feels like they're using software. Huge advance. And it's fairly approachable. You don't need to be like a super expert designer to start making use of these tools. So I think in terms, if you're a business person or, a doctor who's thinking about getting, doing software, these tools are right there for you. And I think that they're a massive change in how we design and test software.
What do public health officials in general not understand about technology that you wish they did? And what do technologists who want to help in public health not understand well enough about the challenges of public health officials that you wish they did?
That's great. Great question. So the public health officials, they're kind of missing two elements, I think. One is the public health official thinks about millions of patients at a time. And so they are really thinking, what big intervention am I going to do that's going to drive change across a lot of people? And it's not so much a technology thing, but the thing they forget is that clinicians do not think that way. Clinicians think about the one patient who's sitting in front of them. And so if you're a public health official sitting in, Delhi, and you ask all the clinicians in a state to go and every time a patient comes, write down these 3 pieces of data, the clinician's looking at you like, what the fuck? Like, I do all this work and it feeds up and I never see it again. And you're like, why the fuck am I doing all this work? I don't even know if you do anything with it. Like, I just feel like I'm shooting stuff up to the center and it never comes down again. That's a huge problem in public health, is that they forget what it's like to be a clinician and they're asking for kind of unreasonable things from healthcare workers, or aren't building in feedback loops that come back down into clinical care. And that's one of the things we try to do as simple, is make it useful for the clinician and make it useful also for the public health official. From a technology standpoint, public health people don't understand 2 things. One, they don't understand how freaking expensive technology is. They're like, oh, I've got $100,000. Let's make a tool to use in 100,000 hospitals in India. That's tons of money in public health. And you're like, yep, that is tons of money in public health. That is a huge budget in many places for public health. In technology, you get what you pay for. And you see the road is littered with tools that were built to tackle problems. And the poor technologists were doing their damn best. And they were severely underfunded and couldn't do user research, couldn't do iterative approach to software development. They, didn't manage to build an MVP, and the system failed. and they got blamed. And you're like, I don't know, guys, like our budget in public health is enormous for Simple. Like we have, well over $1 million a year to invest in the software. So we're 4 years in. We spent, at least $6 million so far on Simple. Public health people will look at that and they're like, whoa, that's like, you're very rich. And if you come from Silicon Valley, you look at that and you're like, that's barely enough to succeed. Even with, more modestly priced engineers than you might get in America. And then the second thing they don't understand about technology is that it's never done. They're always like, when are you going to be finished? And you're like, literally never. Like, if you look at Instagram, I use this analogy all the time. I'm like, look at Instagram, take a picture, add a filter, tag your friends, share it with your community. Simple, really easy, There are literally 1,000 engineers working on that thing, and they've been working on it for 10 years. Like, I don't know what to tell you. Like, it's got billions of dollars into it at this point. It's the simplest software in the world. It doesn't even have a web app, really. Like, are you kidding me? Huge amount of money goes into that.
So for someone in healthcare who has an idea for a company or a way to improve healthcare delivery or an app or something, what advice would you give them?
Oh boy. I would give them advice to get it in front of real customers as quickly as you can. So I've actually, in full disclosure, I forgot to mention, I also personally invested in a speech language pathology tool in Canada called Bodo, B-O-D-O. And a friend of mine, Dr. Greg Schmidt, runs that company. And the big challenge they've had is you can sit down for a long time and try to build what you think is the minimum viable product to be used in the field. But if you get too far and you don't have regular customers using your app, you don't have feedback loops coming from real customers. You get inside your own head and you think, about what customers actually need instead of listening to your customers about what customers actually need. So the part that a company, like Bodo did really well is getting prototypes in front of customers really early. So that doesn't mean like real software, but it means getting your ideas in front of real customers to get their reactions. But then the hard part is crossing the chasm and then building real software and getting that into customers' hands on a regular basis. So you start seeing what people will pay for, you're seeing what people will use, what happens during real clinical care with patients. And obviously within healthcare, it's a really difficult balance because you need enough there to help clinicians to help their patients. You need to get enough basic infrastructure in place that it's safe and that you're respecting patients' privacy and that you're not getting in between patients and their clinicians by being cumbersome. So the bar is higher in healthcare to build an MVP, but get it in front of customers as quickly as you safely can in healthcare. Super important to build those feedback loops in early. And this helps to have a more user-centered approach. Sure, your patients and your customers are using the tool.
What important design truth do very few of your colleagues agree with you on?
I think typography doesn't matter very much. I got in a big fight with people on Twitter about this. Designers love talking about type and like ligatures and like they know all the terms for all the different pieces of letters and stuff. Pick a decent fucking typeface off Google Fonts and just like go for it. It's fine.
Which of your projects or companies was the most fun to work on or create?
I think Firefox. I got to work on the original name and branding for Firefox and then the Mozilla website. And that was my first taste of working for a giant community. So I later on got to work with bigger communities online. But that was my first taste. And Mozilla's a great not-for-profit organization. I think Mitchell Baker and the team at Mozilla are phenomenal. And it felt like we were part of a movement. I mean, it was freaking cool back then. It was really it was a strong community. It was like really grassroots. It felt important. It was really fun.
And the last question here, you wrote an article for Medium about books that designers should read that are not about design. And one of the books on the list was this book here, is it Tufte? Edward Tufte's?
It is Tufte.
Tufte, The Visual Display of Quantitative Information. Why did you include that book on the list?
So that's one of my favorite books. Yeah, The Visual Display of Quantitative Information. I think all of Edward Tufte's books are really interesting. And what's so interesting about it is it's mostly about science and engineering, but it's about how to use design to open up new insights. I remember, there's a couple of really good stories. It's either in that book or one of his others. One, the story of John Snow, for instance, discovering the origins for cholera, where he mapped out all the cases of cholera within the city of London, and was trying to figure out why there were clusters, and then figured out, of course, the famous story that there's a, water pump. He took the handle off the water pump and the cholera outbreak ended. But that's a mapping exercise. It was purely a visual design insight. And he was able to get there because he smartly identified a way to kind of map the data on visually. So stories like that. And I still think when you look at, I think it's Galileo, forgive me if I'm not an expert astronomer, but he was showing how Galileo was mapping the movement of the stars, and he was looking at, one of the planets, and then he could see the moon going back and forth, and then it disappeared. And he took that insight to know that it went behind the planet, and, went from a 2D concept of space to a 3-dimensional concept of what's up in space. And it's like, just by mapping it out more effectively, that was he able to gain that insight. And I think genius is overrated, but that's genius. I mean, that's amazing. And so I think this book is really a useful way to think about how to see beyond kind of your current reality by using visualization more effectively, seeing the truth.
For people that want to learn more about you on the internet, where would you have them go?
Daniel Burka, BURKA.com.
Thank you, Daniel. We really appreciate you taking your time to come on the External Medicine podcast. Thanks again.
I really appreciate you guys having me. Thanks so much.
If you'd like to support us, here are some ways you can help. Subscribe to this podcast wherever you get your podcasts. Leave us a review, preferably a phenomenal review. Visit us at externalmedicinepodcast.com and tell your friends.